First of all, at this ESMO GI, we had a session about precision oncology in gastrointestinal cancers. My role was basically talking and presenting the data on liquid biopsy in advanced gastrointestinal cancers. And of course, like 90% comes from colorectal cancer, there's always also data on gastric cancer, pancreatic cancer, and also biliary tract cancer, of course. When we talk about liquid biopsy, the question is always, what are we talking exactly? Because under this buzzword of liquid biopsy, all kinds of measurements are kind of combined together. So of course, most of the time, we talk about cell-free DNA, cell-free tumor DNA to be exact. But of course, you also have circulating tumor cells, you have exosomes, you have proteins. This is all the same area, which is liquid biopsy. When we look into ctDNA, so cell-free tumor DNA, the question is always, what is the clinical focus, the clinical stage where we can use liquid biopsy? Of course, we know in the metastatic setting, where we have measurable disease, so CT scan is positive, usually there is enough ctDNA that we can look for targetable genetic alterations such as BRAF V600E, IDH mutations, or KRAS G12C mutations, which then, of course, if we are able to find those alterations in the liquid biopsy, we then can also apply the respective targeted treatment. So this is basically the level where we have measurable disease. On the other hand, when we have advanced disease and our patients undergo secondary metastectomy in curative intent, after the surgery there is no measurable disease anymore. But of course, with liquid biopsy, we are enabled to look deeper, basically to do something that is called minimal residual disease analysis. And this is kind of new. We knew this is possible by hematological neoplasms. But now, with a new technique, we are also able to do minimal residual disease in solid tumors, and especially, of course, in GI cancer. When we start with this MRD diagnostics, I think it's interesting to see what should we make out of the data we have so far. So there's data from both gastric cancer and colorectal cancer showing that after surgery, if you're still ctDNA positive after surgery, you have a very high possibility of recurrence. To be honest, it's 100% after 30 days or 4 to 6 weeks after the surgery. The question is, what can we do with this information? If you are ctDNA negative, you have like a 50% chance to be cured or not. And the question, of course, arises, should we treat those patients more rigorously? Should we change the way we do our follow-up surveillance analysis with those patients or not, knowing that there is something ongoing, that the tumor is not completely gone? And I think in this field, we need more studies, we need more trials, prospective trials, say, okay, there is a ctDNA positivity, let's start treatment early on, even though we do not have any CT scan lesions that we can measure. So this is the field of MRD diagnostic. Usually you need a very sensitive method to do this. You need to have the primary tumor already tested, analyzed, and then you're looking for one of the truncated mutations such as APC, P53, or maybe a RAS mutation that you then look with a very high sensitivity in the blood. When you look for genetic alterations in the metastatic setting, the ctDNA needs to be, the level of ctDNA in the blood needs to be higher, because you're not able to really sequence in this so deep, because you want to have more genes tested. And then, of course, you have a different sensitivity, but what can we do with the information coming out of it? Well, if we have difficult to reach tumors, such as biliary tract tumors, and there was a nice study really comparing in more than 1,700 patients the data from tissue-based analysis and liquid-based analysis, it was very clear that mutational analysis is possible with a high sensitivity and a very good specificity. It's getting more difficult when we look for other changes, genetic changes like fusions, because most of the tests today are not really focusing on those fusion genes that are more difficult to find in the liquid biopsy. So if you look for mutations, for most of the tumor it's fine. What we also can do nowadays with the development we have seen with epigenomics, we are also able to find patients that are overexpressed for HER2, that have a Claudin 18.2 overexpression, and of course you are also able to do MSI testing out of blood if the CT DNA level is high enough. So this is always like something you need to test before you go for liquid biopsy. In the metastatic setting where we have targeted treatment options, if you find this target in liquid biopsy, you can start this treatment. The big question that we are not able to answer today is what to do if you are not able to find this mutation. Is it not there, or is it just not shedded into the blood so we miss it by liquid biopsy? So what will the future bring? Well, it's a developing technique, still developing, and now, as I said before, with epigenetics, methylation analysis, we will be able to early on not only say, well, there's still tumor there, but we will also be able to say, well, by epigenetics, we can track down those metastases to the organ of origin. So we will have data saying, okay, there will be a bone metastasis because just by the epigenomics, we are able to really carve out those CT DNA and track it down to the bones, for example, or the liver or the lung or whatever. So this will be the future, and I think we still need a lot of trials to really get more information to treat patients prospectively according to the results of liquid biopsy. This will enable us to really personalize our treatment even further than today, to personalize treatment holidays, and obviously also after resection and curative intent, we will be able to personalize the surveillance period.